Closed reduction is a non-surgical manual realignment of the bone fragments to their previous position. Traction and countertraction are manually applied to the bone fragments to restore the position, length, and alignment of the bone. Closed reduction is usually performed while the patient is under local, regional, or general anesthesia. Traction casting and external fixation or splints or other devices may be used after this manual reduction to maintain alignment and immobilize the injured part until healing occurs. In an open reduction is the correction of bone alignment through an open surgical procedure. It usually includes the internal fixation of the fractures with the use of wires, screws, and pins. The main risk of this form of fracture management are infections, complications associated with anesthesia, and the effects of pre-existing medical conditions such as diabetes, heart failure, COPD. An ORIF, or an open reduction internal fixation, facilitates early ambulation that decreases the risk of complications related to prolonged immobility. And this is just a picture of an open reduction and internal fixation with screws and pins of the right calcaneus. Traction is the application of a pulling force to an injured part of the body. It prevents or decreases the pain, tenderness, or muscle spasms associated with the fracture. It immobilizes the joint or body part and then reduces the fracture. It's going to maintain alignment of bone fragments until healing occurs. With traction, there's going to be a pulling force to attain realignment of the fractured extremity. There's going to be a counteraction that pulls in the opposite direction of the extremity. There are two most common types of traction. They're going to be skin or skeletal traction. Skin traction is generally used for short-term management, less than 48 to 72 hours, until skeletal traction or surgical procedure is possible. Tapes, boots, or splints are applied directly to the skin to maintain alignment, primarily to help diminish muscle spasms and pain in the injured extremity. So that would be the outcome that you're looking for. Improved pain, decreased muscle spasms. The traction weights are usually limited to 5 to 10 pounds. The most common skin traction is a Buck's traction boot. It's a type of skin traction used preoperatively for the patient with a hip or femur fracture to reduce muscle spasms. In skin traction, the nursing considerations is regular assessment of the skin, which is a priority because pressure points in the skin breakdown may develop quickly. You need to make sure that you assess key pressure points every 2 to 4 hours. We also need to evaluate pain, observe for any indications of blood clots, and observe for foot drift. This is a Buck's traction boot, which is a type of skin traction that we said is used to immobilize a fracture and prevent hip flexion contractures and reduce muscle spasms and pain. You can see the weight hanging off the end of the bed. Skeletal traction, generally placed for longer periods than skin traction, is used to align injured bones and joints, or to treat joint contractures and congenital hip dysplasia. It provides a long-term pull that keeps the injured bones and joints aligned. To apply skeletal traction, the surgeon will insert a pin or wire into the bone, and weights are attached to align and immobilize the injured body part. Weight for skeletal traction ranges from 5 to 45 pounds. The use of too much weight can cause a delayed union or a non-union. The major complication of skeletal traction is infection at the pin site and the effects of prolonged immobility. Fracture alignment depends on the correct positioning and alignment of the patient while the traction forces remain constant. It needs to be continuous. For extremity traction to be effective, forces must be pulling in the opposite direction of the extremity, countertraction. It's commonly supplied by the patient's body weight or by weights pulling in the opposite direction and may be augmented by elevation the end of the bed. Traction must be maintained continuously, and we need to make sure that we keep the weights off the floor and moving freely through the pulleys. This just is an example of a closed reduction and then a traction pin placement for left hip location. The most common kind of skeletal traction that you might see is a balanced suspension. A cast is a temporary immobilization device. It's common treatment following a closed manual reduction. It allows the patient to perform many normal activities of daily living while providing sufficient immobilization to prevent stability, to ensure stability. Cast materials are natural, known as plaster of Paris, or synthetic, fiberglass-free or latex-free. A cast generally incorporates the joints above and below a fracture to keep them immobilized to let the site heal. To apply a cast on the extremity if you're using plaster of Paris, the affected part is first covered with a stockinette that is cut longer than the extremity. They then place cotton padding over the stockinette to give it extra padding. If plaster of Paris casting material is used, it needs to be immersed in warm water and then wrapped and molded around the affected part. The number of layers of plaster bandage and the technique of application determine the strength and the hold of the cast. The plaster usually sets within 15 minutes, so the patient may move around without difficulty. However, we need to handle it at this point with gentle pressure because we don't want it to dent. However, it is not strong enough for weight bearing until about 24 to 72 hours after application. The final decision about weight bearing status is determined by the healthcare provider or physician. A fresh plaster cast should never be covered because air cannot circulate. It allows for heat to build up and it may cause burning. And then the drying of the cast is actually delayed. We need to avoid direct pressure on the cast during the drying period, like we said in that first 15 minutes. We need to handle the cast gently with an open palm to avoid denting the cast. And once the cast is thoroughly dry, the rough edges may need to be pedaled to minimize skin irritation from the rough edges and the plaster of Paris debris from falling into the cast, which causes irritation and pressure necrosis. Several strips of tape are placed by the healthcare provider over the rough areas to ensure a smooth cast edge so none of the debris can fall down with inside. After the application of a lower extremity cast or dressing, the extremity should be elevated on pillows above the heart for the first 24 to 48 hours. After the initial phase, a casted extremity should not be placed in a dependent position because of the possibility of excessive edema swelling. After cast application, observe for signs of compartment syndrome, which we'll talk about in a few more slides, and increased pressure, especially in the heel, anterior portion of the tibia, and head of the fibula. This increased pressure is manifested by pain or burning in these areas that is not subsided by pain medication. Casts made of synthetic materials like fiberglass are being used more than plaster because they are lightweight, stronger, relatively waterproof, and provide for early weight bearing. An external fixation device is a metallic device composed of metal pins that is inserted into the bone and attached to external rods to stabilize the fracture while it heals. It can be used to apply traction or to compress fracture fragments and immobilize reduced fragments when the use of a cast or other traction is not appropriate. The external device holds fracture fragments in place similar to a surgical implanted internal device. External fixation is often used in an attempt to salvage extremities that otherwise might have been amputated. Because the use of an external device is a long-term process, ongoing assessment for pin loosening and infection is critical with an external fixation. Infection may require removal of the device, and we know what local signs of infection look like: exudate, purulent drainage, erythema, redness, tenderness, and localized pain directly at the site. We need to make sure that we provide meticulous pin care site and that we also instruct the patient and the caregiver on doing so. Although each physician has their own protocol for pin care cleaning, a lot of hospitals are using chlorhexidine 2 milligrams per milliliter as their pin care site daily. But other times we've seen half-strength hydrogen peroxide used or just sterile saline. But we need to make sure that it's done daily. This is just a picture of an external fixation device of the hand, and then on the right it's a picture of the knee, femur, and tibia. The external fixator is attached directly to the bones by a percutaneous transfixing pins or wires. Patients with fractures experience varying degrees of pain, usually associated with muscle spasms that can actually make the fracture worse or make some of the vascular nerve damage escalate even worse. Central and peripheral muscle relaxants such as Soma, Flexeril, or Robaxin may be prescribed for management of pain associated with muscle spasms. The threat of tetanus from an open fracture can be reduced by administering tetanus and diphtheria toxoid for a patient who has not previously been immunized, or if it's closer to that 10-year mark, if it's expired. Bone-penetrating antibiotics such as cephalosporin, Ancef, are used prophylactically before surgery. An adequate energy source is needed to promote muscle strength, tone, build endurance, and provide energy for ambulation and gait training. The patient's dietary requirements must include adequate protein, vitamins such as calcium, phosphorus, and magnesium to ensure optimal tissue and bone healing. Low serum protein and vitamin C have been known to interfere with tissue healing. Immobility and bone healing increases calcium needs. 3 well-balanced meals a day usually provide the necessary nutrients, and a well-balanced meal should be supplemented by adequate fluid intake of 2 liters to 3 liters per day to promote optimal bladder and bowel function. Because we know these patients are going to be at risk for constipation due to their immobility and laying down or being somewhat flat, and they're also going to have problems with stagnant urine due to their decreased gravity and decreased mobility. So we need to make sure that we flush them with fluids so that we decrease that stagnant urine and that stasis of urine, and also to improve bowel function. Adequate fluid and fiber diet with fruits and vegetables can also help with constipation. If immobilized in bed with a skeletal traction or in a body jacket brace, we need to instruct patients to eat 6 small meals a day so that they don't overeat, because a lot of that can cause abdominal distension or cramping. If we're looking at subjective nursing data on a patient with a possible fracture or fracture, we would obtain the following health information: a traumatic injury, prolonged immobility. We have the beginning stages of osteoporosis, which is osteopenia. We have a diagnosis of osteoporosis, which is making us more susceptible to the effects of wear and tear, making it easier for us to fracture. Are we on certain medications that increase that risk? Steroids, some of the anti-seizure medications, anticonvulsants, Dilantin, phenytoin. Have we had previous surgeries or other treatments that put us at risk for fractures? Do we take any estrogen or any oral contraceptives or any calcium vitamin D supplements? We're going to perform a focused physical assessment for the following clinical manifestations. Are they apprehensive? Which could mean that the patient has shock, hypovolemic shock, if there's been blood loss associated with an artery being cut with the fracture. Is there guarding, which we know that there could be some guarding with the fracture? Do we see any skin lacerations or open lesions? Edema. One of the biggest things that we need to look for in somebody who has a fracture is their distal pulses. Do they have decreased or absent pulses? Is the temperature of their skin cool versus warm? And we know that a delayed capillary refill is greater than 3 seconds. So anything greater than 3 seconds would indicate poor perfusion or poor vasculature flow to that area. Is their sensation in their leg altered? Is it different? Do they have an obvious deformity in the leg? Restricted loss of function? Is there a shortening or rotation of the extremity? We need to place special emphasis on the regional distal to the site of the injury. We need to document these clinical findings before fracture treatment is initiated to avoid doubts about whether a problem discovered later was missed during the original examination or was caused by the actual treatment, the reduction, the surgery, the immobilization. If we're doing a neurovascular assessment, which is high priority in a patient with a fracture, we need to realize that musculoskeletal injuries have the potential for causing changes in the neurovascular status of an injured extremity. Application of a cast or dressing, poor positioning, and physiological responses to the trauma can cause nerve or vascular damage, like we said, usually distal to the injury. The neurovascular assessment should consist of looking at the color, the temperature, the cap refill, the pulses, and whether or not there's edema at the site, and also looking at the peripheral neurologic assessment. What's their motor function? Do they have pain, and what's their sensation? Many diagnoses for the patient with a fracture may include, but are not limited to the following: impaired physical mobility related to the loss of integrity of bone structures, movement of bone fragments, and prescribed movement restrictions, if it's ordered by a physician. Risk for peripheral neurovascular dysfunction related to vascular insufficiency and nerve compression, secondary to the edema and a mechanical compression by the traction, splints, or cast. Acute pain related to the edema, the movement of bone fragments, and the muscle spasms. And then readiness for enhanced health management. The overall goals for our patients with a fracture is to have healing with no associated complications, obtain adequate pain relief, and achieve maximal rehabilitation potential. Health promotion with a fracture to prevent. We need to teach patients or people in the community to take appropriate safety precautions to prevent injuries while at work or at home, when driving or when participating in sports. We need to be an advocate for personal action known to reduce injuries, such as wearing seatbelts, driving within the speed limit, warming muscles up before exercising, using protective athletic equipment, and using safety equipment at work. We need to encourage individuals, especially older adults, to participate in moderate exercise to aid in the maintenance of muscle strength and balance. To reduce falls in this age group, there's also, we need to urge them to wear non-skid, hard-soled footwear and assess their living environment for safety risks. Are there slip-resistant rugs in their home? Do they have handrails where they need to be? Do they have handrails on the steps coming in and out of their home? We also need to stress the importance of adequate calcium, vitamin D intake, and exercise to build their bone mass. If surgical intervention is required to treat a fracture, patients will need preoperative preparation. In addition to the usual preoperative nursing measures, we need to inform patients of the type of immobilization and assisted devices that will be used and the expected activity limitations after surgery. We need to assure patients that nursing staff will help meet their personal needs until they can again meet or resume their own self-care. We need to talk to patients about pain medications and remind them that it will be available as needed. In general, post-operative nursing care and management are directed towards monitoring vital signs and applying the general principles of post-operative nursing care. Like we mentioned before, we need to frequently assess their neurovascular status of the affected extremity as necessary to detect early and subtle changes. We need to closely monitor any limitations of movement or activity related to turning, positioning, and extremity support. Pain and discomfort can be minimized through proper alignment and positioning. We need to carefully observe dressings or cast for any signs of bleeding or drainage. We need to report a significant increase in the size of the drainage. If a wound drainage system is in place, regularly measure the volume of drainage and assess its character. Is it bloody? Is it brilliant? Also assess the patency of the drainage system using a septic technique to avoid contamination. And drainage systems might be a JP or a hemovac, which we did talk about in the lab. Additional nursing responsibilities depend on the type of immobilization used. Patients often have reduced mobility as a result of a fracture. Plan care to prevent many complications associated with immobility. Prevent constipation by increasing patient activity and the maintenance of high fluid intake, more than between 2 liters to 3 liters a day, unless contraindicated. If this is a patient with heart failure, we're not going to give them that much fluid per day. We need to make sure that they get enough bulk and roughage in their diet. If these measures are not effective in maintaining the patient's normal bowel elimination pattern, administer stool softeners, laxatives, or suppositories. We also want to maintain a regular time for elimination to promote bowel regularity. Another risk factor that these patients have who are immobile is renal calculi, or like renal kidney stones, can develop from bone demineralization related to reduced mobility. There's also going to be an increased calcium in the blood because we're not increasing the remodeling process because we're immobile. So there's going to be more calcium available in the bloodstream. It's going to cause a rise in the urine pH, and stone formation can result from the precipitation of this calcium. Unless contraindicated, we want to make sure these patients drink adequate amounts of fluid to clear these calculi or to avoid the precipitation of them. Rapid decongestioning of the cardiopulmonary system can occur as a result of prolonged bed rest, resulting in orthostatic hypotension and decreased lung capacity. Unless contraindicated, these effects can be diminished by having the patient sit on the side of the bed and allowing the patient's lower limbs to dangle every once in a while, and having the patient perform standing transfers if applicable by the physician's order. When the patient is allowed to increase activity, we need to monitor and assess for orthostatic hypotension. And as always, in these patients who are mobile, to improve lung expansion, we're going to be doing the incentive spirometer use and coughing and deep breathe. We also need to monitor and assess these patients for DVT or pulmonary emboli or embolus. When slings are used for traction, we need to regularly inspect exposed skin areas. Persistent skin pressure may impair blood flow and cause injury to the peripheral neurovascular structures. Observe skeletal traction or external fixation pin sites for signs of infection. Pin site care may vary, but often includes regularly cleansing with chlorhexidine, rinsing the pin site with sterile saline, and drying of the area with sterile gauze. External rotation of the affected extremity is a classic assessment finding for a patient with an unrepaired hip fracture. If skeletal traction is ordered preoperatively, or if skin traction is ordered preoperatively, Apply traction without attempting to reposition or realign the extremity. Keep the patient in the center of the bed in a supine position to provide adequate countertraction. To offset possible problems associated with prolonged immobility, discuss specific patient activity with the healthcare provider. If exercise is permitted, encourage participation by the patient in a simple exercise regime based on activity restrictions. Encourage the patient to participate in frequent position changes, range of motion exercises of the unaffected joints, deep breathing exercises, isometric exercises to the affected joint, and use of the trapeze bar if permitted to raise the body off the bed for linen changes and placement of the bedpan. We also want to encourage and facilitate the hospitalized patient to stay connected with family and friends through social media resources to meet their psychosocial needs. For ambulatory cast care, we need to teach patients how to monitor for complications, such as increased swelling and edema that can reduce vasculature flow to that affected area. So we want to make sure that we're doing a good assessment of that site, checking distal pulses. We also want to make sure that we assess patients for any foul odor or sores, which could indicate an infection under the site of the cast. So after cast application, we want to keep it elevated above the heart for the first 48 hours. Apply ice around the area, but not directly on the cast for the first 24 hours. We need to check with the physician, depending on what kind of material is used for the cast, to see if we can get it wet. We want to make sure that we don't cover the cast for prolonged periods because we know there's no air circulating and it can heat and lead to burns. We want to make sure that when it's possible to exercise the joints above and below the cast. We want to make sure that these patients, they check their weight-bearing status with the physician. Most of the times we shouldn't be bearing weight on a cast for the first 48 to 72 hours. And this is common sense, but we don't need to be pulling out any padding that's cushioning the skin underneath the cast, or we don't need to be sticking anything like a wire hanger under the cast to itch it. You can use a hairdryer in cool setting, or you can use a little bit of ice around the site to help with the itching. When the patient begins to ambulate, know the patient's weight-bearing status and the correct technique if the patient is using an assistive device. There are multiple different degrees of weight-bearing ambulation. There's non-weight-bearing, which means you cannot put any weight on the involved extremity. Toe touch weight-bearing, which would be contact with the floor to maintain balance. Partial weight-bearing, which is 25 to 50% of the patient's weight bear. Weight-bearing is tolerated, meaning the patient gets up and moves based on their pain and tolerance, or full weight-bearing without any restrictions. Devices for ambulation range from a cane to a walker or crutches. The healthcare provider decides which device is appropriate for a patient, balancing the need for maximum stability and safety versus maneuverability required in small spaces such as their bathroom. Discuss with the patient his or her lifestyle requirements and select a device that allows each patient to feel most secure and independent. The technique for using assistive ambulation devices varies. The involved limb is usually advanced at the same time or immediately after the advance of the device. The uninvolved limb is advanced last. In almost all cases, canes are held in the hand opposite the involved extremity. Place a transfer or gait belt around the patient's waist to provide stability during the learning stages of using an assistive device. Discourage the patient from reaching for furniture or relying on another patient for support. If the patient has inadequate upper limb strength or poorly fitted crutches, he or she bears weight on the axilla rather than on the hands, endangering the neurovascular bundle that passes across the axilla. Patients who must ambulate without weight bearing require sufficient upper limb strength to lift their own weight at each step. Because the muscles of the shoulder girdle and upper arm may not be accustomed to this work, patients require vigorous and diligent training and preparation for this task. Pull-ups, push-ups using the overhead trapeze bar, and lifting weights develops the tricep and bicep muscles. Straight leg raises and quadricep setting exercises strengthen the quadriceps. Short-term rehabilitation goals address the transition from dependence to independence in performing simple activities of daily living and preserving or increasing the strength of the patient and their endurance. During the rehabilitation phase, help the patient to adjust to any problems caused by the injury, such as separation from the family, financial impact of medical care, loss of their income if they've lost their job, or the potential for lifetime disability. We need to make sure that we offer support and encouragement while actively listening to the patient and caregiver's concerns. The majority of fractures heal without complications. However, death after a fracture is usually the result of damage to an underlying organ or vascular structure from the complication of the fracture or immobility. Complications from the fractures may be direct or indirect. A direct complication may be from a bone infection like osteomyelitis, a bone union, or avascular necrosis of the bone. An indirect complication might be associated with blood vessel and nerve damage, resulting in something known as compartment syndrome, blood clot, pulmonary emboli, fatty embolic syndrome, or breakdown of skeletal muscle, and that puts us for a setting for rhabdomyolysis and renal failure or hypovolemic shock. Most musculoskeletal injuries are not life-threatening. However, open fractures or fractures accompanied by severe blood loss or that damage vital organs are medical emergencies requiring immediate attention. Open fractures and soft tissue injuries have a high incidence of infection. Devitalized and contaminated tissue is an ideal medium for common pathogens. Treatment of the infection is costly in terms of extending nursing and medical care, time for treatment, and loss of patient income. Delayed or ineffective treatment can lead to the development of chronic osteomyelitis. Open fractures require aggressive surgical debridement. The wound is initially cleaned by pulsating saline lavage in the operating room. Gross contaminants are irrigated and mechanically removed. Contused, contaminated, and devitalized tissue are surgically excised. And the extent of the soft tissue damage determines if the wound will be closed at the time of surgery and if it requires repeat debridement and closed suction drainage and skin grafting. Depending on the location and extent of the fracture, reduction may be maintained by external fixation or traction. During surgery, the open wound may be irrigated with antibiotic solution. Antibiotic-impregnated beads may also be placed in the surgical site, and the patient may have antibiotics administered IV for at least a week during the postoperative phase. Veins of the lower extremities and pelvis are highly susceptible to thrombus or clot formation after a fracture, especially a hip fracture. VTE may also occur after the total hip or a total knee replacement. In patients with limited mobility, venous stasis is aggravated by inactivity of muscles that normally assist in the pumping action of venous blood from the extremities to the heart. Because of the high risk of VTE in the orthopedic surgical patient, prophylactic antibiotic or anticoagulants can often be used, such as Lovenox, heparin, and sometimes in other cases, Xarelto or warfarin. In addition to wearing compression gradient stockings or TED hose and using sequential compression devices or SCDs, the patient should dorsiflex and plantar flex the ankle of an affected lower extremity against resistance and perform range of motion exercises on the unaffected leg as long as the physician approves of this. Another complication of a long bone fracture, pelvic fracture, is another fracture is called compartment syndrome. This is going to be a condition in which swelling within the compartments causes an increased pressure within a limited space of the extremity. Compartments typically compose blood vessels, nerves, and tendons. The compartment syndrome is where there's this massive amount of swelling or compression that's going to put pressure on the blood vessels, nerves, and tendons. And it's going to compromise the neurovascular function of the affected extremity. There's going to be a reduction in perfusion below what is needed for adequate tissue viability or adequate tissue maintenance. So these patients are going to have massive amounts of ischemia that can lead to infarction. It's usually going to involve the legs, but can occur in any extremity where there is a fracture. Like we said, it's typically associated with a traumatic trauma or a very serious traumatic fracture, extensive tissue damage, or crush injuries to the extremity. Some of the biggest manifestations that you're going to see with compartment syndrome is pain at the site that's not going to be relieved by opioids or narcotics. So you're going to have increased escalating doses of pain medication that doesn't help. You're going to have increased pressure or swelling within that affected extremity. You're going to actually feel and see the extremity getting bigger, putting all that pressure on the inside to the nerves, tendons, and vessels. So as a result, because you're compressing and you're reducing the blood flow, you're going to start to have paresthesias, where the patient's going to start to feel numbness, tingling. The extremity is going to get cool. It's going to start to lose its color. It's going to get very pale. In last case scenario, it could be loss of function. And in very worst case, there could be a complete absence of pulse. So this ischemia can occur within 4 to 8 hours after onset of the progression of compartment syndrome. It can occur initially or may be delayed several days after the initial insult or injury. And so, treatment is early recognition and response. So this is just kind of an example or picture which shows kind of the compartments that hold the nerves, blood vessels, and some of the tendons. So collaborative care, so we need to be prompt and we need to diagnose this early. So we need to be doing regular neurovascular assessments on a patient who has a traumatic fracture or any fracture, or somebody who's had a casting placed, or somebody who's had a crush injury or any kind of surgery to the leg where you might think, okay, there's going to be increased blood in that area, increased swelling. We need to notify the physician if the pain is unrelieved by drugs or it's out of proportion to the injury. So there's escalating amounts of medications we're giving and they're still having pain. Paresthesias, the numbness, tingling, is an early indicator. And because in compartment syndrome, we cause muscle damage and we release the myoglobin into our vascular circulation, it can get caught within our kidneys and our renal tubules and lead to rhabdomyolysis and acute renal failure. In these patients, because yes, they have a lot of swelling, but they also have poor arterial flow, we don't want to be elevating our leg and decreasing what minimal flow we have. We also don't want to put any ice in these patients because it's going to cause vasoconstriction, and we want to keep what lack of blood flow we have, even if it's little. We don't want to decrease it anymore. So the surgical treatment for this is emergent fasciotomy. So they're going to actually do a surgical decompression where they're going to cut along the sides of this extremity and open these compartments up and let them drain. In very severe cases where early detection has not been identified, they're going to do amputations. So this is just an example of a compartment fasciotomy. So these fasciotomies are going to be left open until the underlying condition or until the condition starts to reverse, and so they can be safely closed. Some of these patients, depending on the circumstances why they needed this, they also might be wound backed. So we might put a negative pressure device to them to increase their healing. Another complication of a fracture or even joint replacement arthroplasty is something known as fat embolism syndrome. It's the presence of systemic fat globules from fractures that are distributed into tissues after a traumatic skeletal injury. So the theory is that fat is released from the yellow bone marrow and enters the circulation where it can cause obstructions. So fat embolisms or fat emboli is a factor of many deaths associated with fractures, and the most common is in the long bones, like our tibia, femur. This is just another example that shows fat embolism. So fat embolism is a little bit different than a pulmonary embolism because it does, yes, affects the lungs and can affect the right side of the heart, but it also can move through the pulmonary vasculature and make its way on the other side to the arterial circulation, and it can also go to the brain, to our cerebral circulation. So most of the manifestations can occur within 24 to 48 hours. So if it affects our pulmonary vasculature and the right side of our heart, we're going to see chest pain, pleuritic, increased respiratory rate, increased heart rate, difficulty breathing, and in later cases, we're going to see cyanosis. If it goes to our cerebral circulation, we're going to see neurological manifestations, confusion, memory loss, headache, restlessness, irritability. And then to kind of round off the triad of respiratory and neurologic manifestations, these patients are also going to have petechiae, or there's small kind of red dots that indicate capillary ruptures. And this stems from the embolization of these fat emboli to these capillaries. So there's going to be capillary rupture and small bleeding. And we're going to see it in our chest wall, our necks, our conjunctiva. So there are no specific lab tests available to diagnose, but we might see some EKG changes or chest X-ray changes if it significantly affects our lungs on the right side of our heart. So the treatment obviously is directed at prevention. So when we have a fracture, we want to be careful to immobilize it and handle it with care and not handling it too much until it has been stabilized or repaired. So management is supportive, and it's really symptomatic management. So in these patients, we're going to give them adequate fluid resuscitation. We're going to give them blood if they're hypovolemic. And in certain situations, we're going to correct their acidosis if the emboli have caused significant tissue damage, which has led to the breakdown of tissue and infarction, which leads to acidosis. We're going to correct that. These patients, we're going to do a little bit of coughing and deep breathing. And in severe cases with the supplemental oxygen, sometimes it may not be enough. We may go a little bit more invasive in our support of their oxygenation. So we might do a BiPAP, which is an intermittent positive airway pressure, where we put the mask on them and we help their inspiratory support, and we also help keep their airway and their alveoli open. And then in severe cases where these patients decompensate very quickly, we might need to intubate them with a breathing tube and do all the breathing for them. One of the biggest complications from fat emboli syndrome is something known as ARDS, or acute respiratory distress syndrome. The emboli in themselves can set off an inflammatory response, which can cause fluid to seep into our alveoli, and which can also cause collapse and a decrease in surfactant release production within these alveoli. So you have massive collapse and massive fluid shifts into our alveoli, which can cause decreased or impairment in oxygenation and gas exchange. So in our patients with our fractures, our expected outcomes with them is to be satisfactory in their pain management, demonstrate appropriate care of their cast or immobilizer, have no peripheral or neurovascular dysfunction, and experience no complications of bone healing.